So moving on to our next speaker now, Marie Lemm. She is a clinical research fellow based at Imperial College in London. Welcome, Marie. She's been working on both the Oxford COVID vaccine study and the Imperial COVID vaccine trial, so she's been incredibly busy the last few months. She's also a postgraduate student where she's researching the immunology of vaccines. We're delighted to have you with us today, Marie. The title of her talk is Risky or Protective Antibodies, an update on theory and research of dependent enhancement. Over to you, Marie.
Thank you very much for the introduction. I will just bring up my slides. Great. So I'm presenting today about vaccine-associated disease enhancement, and while I'm by no means an expert on this, I thought it was a very interesting topic as it's a very important question. Certain participants who have been taking part in the COVID-19 vaccine trials have, especially in the process of consenting a participant, you can imagine that is quite a tricky thing or a daunting thing to try and explain to someone about to enroll in a vaccine trial that there might be a theoretical risk around these vaccines. So I'd like to present to you some of the background reading on this topic and where we are at this point in time. So first of all, I thought I'd just clarify some definitions. So vaccine-associated enhanced disease is deemed an immune response that's causally linked to vaccine, meaning that there's a higher risk of an adverse outcome in those people who have been vaccinated and subsequently infected, as opposed to those who have not been vaccinated. And antibody-dependent enhancement specifically refers to the antibody-mediated component of that, and that has been observed in natural infections and hypothesized with some vaccinations in the past. The general term vaccine-induced immunopathology may refer also to autoimmune disease induced by vaccines, which can occasionally, rarely be the case, which I will not be focusing on today. So the key topics I'd like to cover are some preclinical data and theoretical aspects, some clinical vaccine experience, and then current implications for global vaccine development for COVID-19. I should start, maybe just mention in Katrina's presentation regarding cats and a specific enteric coronavirus, which affects cats, which causes these cats to have a relatively common aberrant immune response, which is thought to be due to mutations in this coronavirus, which allows subsequent infections to cause an enhanced disease, which presents with inflammatory cells and immune complex deposition and granuloma composition in various organs. So this is one of the kind of things we know about cats, but I'd like to focus in this presentation some background about diseases that we know affect humans, not just coronaviruses, and then move on to some preclinical data specifically around coronaviruses. So we know the paradigm in dengue virus is a single positive stranded RNA virus which affects tropical regions and can cause a severe hemorrhagic fever shock syndrome. And there are 4 serotypes which are related to dengue, and it's been shown in vitro that when you have one serotype and then a subsequent a second infection with a second serotype, that the cross-reactive antibodies can actually mechanistically enhance infection through an Fc gamma receptor mechanism, where those immune cells, such as macrophages shown in the diagram here, can actually facilitate viral entry and increase virion production. And this is something that should be noted, that in clinical disease, that this rare kind of severe dengue is actually quite rare, with an attack rate of about 0.5% in one study, and associated with a narrow range of neutralizing antibodies. And I'll come back to that in a moment. But just to give you an overview of some previous concerns around enhanced disease with vaccines. So the case studies present are measles, RSV, and dengue. And in measles in the 1960s, a formalin inactivated measles vaccines was subsequently withdrawn in 1967, and that was because there was a concern that the children who received this vaccine and then were exposed to the wild type virus in community outbreaks actually had a severe and atypical form. And the rate at which this occurred varies between different studies, but is cited anywhere between 15 to 60% of those children vaccinated. And some of these atypical features included an atypical pneumonia, as well as this atypical rash, as well as eosinophils and hepatic dysfunction. Another study showed that when live attenuated measles vaccine was given after a formalin inactivated measles, there was some papular lesions which showed immune complex deposition at the vaccination site. And this is a paper from the 60s which summarized those cases and the atypical features. Moving on to another case study of also a formalin inactivated vaccine in the 1960s for the for respiratory virus RSV. Again, this study showed that while there wasn't an overall increase in the incidence of RSV infection, there was a higher hospitalization rate for severe RSV in the vaccinated group, specifically in age group from 6 to 11 months, and there were 2 fatal cases in this group. And the rate of hospitalization also higher. In RSV, neutralizing antibodies are formed, and they're primarily directed against the fusion protein. And it was shown that in those that were vaccinated and then developed RSV, 14 out of 15 of those had neutralizing antibodies, but seemed to have a higher ratio of fusion protein binding antibodies than RSV neutralizing antibodies compared with the natural infection controls. And the post-fusion state of the protein is actually the predominant conformation after formalin inactivation. And this diagram here just shows all these different proteins on the surface of the RSV, and some of the mechanisms that have been proposed are that there were off-target antibody responses to other RSV proteins, and that there were some antibodies directed against non-protective fusion protein epitopes, as well as animal studies which support this abnormal T helper cell response, which has been described in the previous presentations, and possibly a lack of the antibody affinity maturation in young children, which might explain some of those age-related differences. But it should be noted that there's not really a reliable method in differentiating between enhanced RSV disease and severe RSV infection, unlike with the measles, where there were some characteristic features of enhanced disease. Moving on to the next case, a study of dengue. So we know, kind of presented dengue as a paradigm for suspected antibody-dependent enhancement, and this study is a long-term pediatric cohort in Nicaragua, which showed that the risk of severe dengue disease was highest within a very narrow range of pre-existing anti-dengue antibody titers, while high antibody titers protected from symptomatic dengue disease. So I think this just demonstrates how complicated this can get with different titers of antibodies. Kind of, different correlates of protection have to be considered here, and that was certainly an issue for the dengue vaccine. Dengvaxia, which is currently licensed in 20 countries, and it was licensed in 2015 for the age group of 9 years and older. But uptake of that vaccine is quite poor due to the findings of large phase 3 trials, which were enrolling over 30,000 participants aged between 2 and 16 years. Now, these studies did show that there was vaccine efficacy over a 25-month period from the first dose, and that was of a 3-dose immunization regimen. That vaccination reduced severe dengue by 93% and dengue hospitalization by 82%. However, there was an increased risk of hospitalized dengue in the 2 to 5 year age group in the 3-year follow-up, and because of this was only licensed in the age group of 9 years and above. And this slide presents the WHO policy position on the dengue vaccine, published in 2018, which summarized that the benefits of the intervention really depended on the serostatus of the vaccinee. While there was a reduction in severe dengue over 5 years for those aged 9 years and above, with those vaccinated, there was an incidence of the severe dengue of 1 in 1,000, as opposed to the unvaccinated, where this is a 4.8 in 1,000. We can see that the harms of the intervention are that there were excess cases of hospitalized and severe dengue in seronegatives prior to vaccination, and in fact there was an incidence of severe dengue of 4 per 1,000 seronegative versus 1.7 of those seronegative who were unvaccinated. So really, population benefit depends on the dengue seroprevalence. And of course also the incidence of dengue to try and weigh the risks and the benefits. So very difficult weighing for policymakers in this case study. So now just to summarize some of the mechanisms of immune enhancement. So we've talked about antibody-dependent enhancement, which might be through a viral entry mechanism affecting specific immune cells, macrophages, through their receptors to facilitate entry, as well as immune complex formation. So if we've got these antibodies which aren't really doing their job, aren't neutralizing or the right epitopes, then those antibodies can form antigen-antibody complexes and be deposited and cause damage. And the cellular mechanisms are specifically hypothesized around the T-cell response and eosinophils, which might be potential markers. And certainly, as presented in the previous the previous presenters, these are things that are, closely looked into for the vaccines for COVID-19. So I'd like to present now on coronaviruses and animal models, preclinical data. Why has this been a concern? So, and I just wanted to make a note that these are some of the common animal models that have been used, but the note of caution is that actually we don't know how good are these animal models in actually modeling different disease with coronavirus. For example, mice, they don't express the receptor ACE2, which SARS-CoV-2 uses to get into the cells, so that we need to use transgenic mice models to have them infected. Then the next pictures of ferrets, which seem to be a good model, but actually they predominantly show upper respiratory tract infection. And then mink seem to be quite a suitable model, certainly easily infected, but quite difficult to handle under lab conditions. And then rhesus macaques are kind of at the top of the animal model, who again mainly show mild disease. So why has there been a concern? Peter mentioned this earlier, that regarding MERS-CoV-2. So this is just a snapshot of some of the studies, specifically those that did show some immune enhancement in mice who were given inactivated virus vaccine. They showed eosinophilic pathology, whereas in the other trials that he's mentioned, that was not the case for the Chadox vector. Rabbits who were infected with live virus did show some immunopathology, but interestingly, no clinically evident disease. And then moving on to SARS-CoV-1 in a ferret model. Again, we've got some conflicting evidence here that infection with a live virus versus no immune enhancement, whereas the modified virus vaccinia Ankara vaccine expressing the spike protein and a nucleocapsid protein did show evidence of enhanced hepatitis, but again, no clinical signs that were obvious in these ferrets who were subsequently challenged with the virus. And this slide is quite busy, but the key point really from it is that there's been conflicting evidence in preclinical data from mice, again raising questions how good are these animal models and actually predicting anything for humans, and there are a large number of different vaccine technologies, both with adjuvant and without, show conflicting results. Some show no evidence of any immune enhancements. Others do show this pathology, especially the evidence of eosinophils in the lung.
Nana Marie, just to interrupt, I'm sorry. You've just got a couple of minutes left. Is that okay?
Yeah, that's fine. I will sum up now. So just to show the evidence in the rhesus macaque models, there's been no evidence so far with these different vaccine platforms that there is any immune enhancement. And then, as previously presented by Katrina, these current phase 3 vaccines, the interim analysis, there was one severe case in the Pfizer trial, but importantly, of 170 cases of COVID, 162 were in the placebo and 8 in the vaccine group, with the 10 severe cases of those 9 in the placebo and only 1 in vaccinated group. So far from the data we've got so far, that's very reassuring. But as Suzanne presented in her presentation, it's very important to get these larger numbers and to consider all the factors of the incidence of infection in the population being studied. Equally, there's been some interest in the cases of reinfection, and some of those showing a more severe form of disease, and both in healthy and in immunocompromised patients. But these are a few case studies so far. What we really need is broad testing and surveillance to gather that epidemiological data regarding how many individuals actually who had a primary infection and then a secondary infection who were actually asymptomatic, rather than potentially the bias of picking out these symptomatic individuals. So implications for vaccine design, to summarize, the vaccine platform may be crucial, and different aspects of inactivation might change the immunopathology that is seen so far. In clinical vaccine trials, we have not seen this pathology, but crucially for the study design, the implications are we need to closely compare rates of COVID-19 between vaccinated and controls, and we also need to consider a case definition. If this were to be, this theoretical risk were to crystallize out, do we see a severe form of COVID, or do we see an atypical form? And as we're still learning a lot about COVID, can we differentiate those? So to conclude the presentation, so far we are reassured from what we've seen. We can't currently comment on any specific vaccine technology or platform to be prioritized, but this may need to be monitored carefully if any safety signal emerges for any specific platform. We need to be mindful of the severe disease case definitions and monitor this closely in the post-licensure period. Thank you very much.
Nana Marie, thank you for a fantastic talk. That's really great.